you talked about the handcuffs. I know you and I have talked offline about the use of other restraints, right? Specifically, whether you ad hoc something or buy something purpose made.
Yes, I have a very strong opinion on this. Yeah. Sorry.
We're well aligned on this. I wanted to get it out there.
It's the 21st century. They make commercialized soft restraints for a reason. I think that if, for whatever reason, if your medical direction does not supply them to you, then that's your responsibility to purchase them.
It is inexpensive, correct?
It is an expense, but it's not an ungodly expense. Right. It's just, in my opinion, it's a requirement. You should have them on your ambulance. You should have them on your ambulance for a multitude of reasons. It's safer for the patient. They're called soft restraints for a reason, so that the patient doesn't injure themselves while we're chemically sedating them. Yeah. And you're not trying to MacGyver.
It's not roll a Curlex or it's not appropriate. No, this day and age. Yeah,
no, and back to the point about the ambulance goes off the cliff. I can't remember which doc said that. Okay, how am I, once I tie 50 knots in that, then how am I going to get that patient out of that situation quickly? Where these restraints are made to be released quickly. They're for a safer transition of care when we get to the facility, when we need to move the patient over from our cot to your bed. It makes sense. In my opinion, if people are making excuses that it costs too much, in my opinion, that's bullshit. I'm sorry. I'm going to say it. If you want to run an elite organization, then you need to buy some of the tools that you need to have in your toolbox.
Well, how often are you using them, right?
Exactly.
You will use them during the year?
Rarely.
It's not. It's like an IV
exactly.
It's not nasal cannula.
It's not a saline flush. I'm going to go through 10 of those a day. I don't know. I have a very strong opinion on that, and
so we're well aligned from the soft restraint perspective. I historically have gone one step further and put non-locking leather restraints, understanding that my agency would transport a lot of patients that were in leather restraints at the sending facility. Not appropriate. Same handcuff rule, right?
Yep.
Yeah.
You've got a locking leather restraint. I put that in my ambulance. I'm rubber side up in a ditch. How do I get them out quickly, right? And products are made where it's still a leather restraint, but the lock is just a leather strap that goes through a loop, right? Now, the rub there is simply you have to use all four. You got to do all four corners, right? So where you may have somebody just tethered with one in the hospital and they're walking circles around a central point on the bed. I've seen it happen. I'm just laughing at it, right? Not best practice, obviously. No. But it's been done. You got to, because even the most doped up, hell-dolled up, geodoned up, trazodoned up patient can go and pop that off and be out of those leather restraints. But going back to they can pull, they can kick, as hard as if they come off sedation. It's a much more durable product. So I actually supplied both of those, and there was a bit of expense to the leather restraints, but it kept people safer, right? Because when they go full Hulk on a piece of, although purpose made, like a Posey restraint or something, you can rip that right in half, right? If they come hard off sedation, right?
Oh yeah, and I think both have their place. I have a firm belief that. It needs to be a commercialized device.
Yep.
Yeah, that's designed for the better safety of the patient, and it is easily removable so that you can remove that patient from whatever situation it may need. Maybe.
If you tie something also, we also worry that you may cut off circulation in the extremity. And so our protocol mandates 15-minute neurovascular checks. The hospital should be doing that too, but unfortunately, I'm sure many hospitals don't always document that with their, at least at that degree of frequency. And so if you're tying something tight, you're more likely to potentially cut off circulation and cause permanent injury. We know tourniquets can be on for 2 hours, but we don't want 4 extremity tourniquets on for a long period of time. And then you brought up the point of four-point restraints are key so that the person doesn't break out of one and escape. But the other thing is, if they're walking around one point, they're going to continuously twist their arm and potentially make something a lot tighter. Yeah. And so if we have 3, 2, or 1 restraints on, they're more likely to twist themselves in a way that compromises their ventilation or circulation. So if you're going to put any restraint on, it must be 4 points.
Go 4 corners.
End of story.
Yeah, I think we have that clearly outlined in the protocol. 1 up, 1 down.
Yep. 1 arm, 1 up, and down. Yep.
Yeah, one arm, one.
Not one leg up, one leg down.
I don't know what protocol you're reading.
You gotta
Karma
spin,
Sutra.
You gotta spin the picture. You gotta spin that picture.
You mixed your bedside reading up again, John.
Wrong protocol book.
But I think too, and another thing to kind of piggyback off of that is making sure that when you're working with any type of chemical restraint and physical restraint, that you do it appropriately, you follow your protocol wherever that may be, like, because everybody that listens to this might not be under a university hospital's protocol, and, you know, positioning of that patient is key. You know, if you have given them a sedative, positional asphyxiation is a real thing. So you do not want to put your patients on their side, face down, have the ability to kind of, you know, walk around the bed and impede their airway or anything like that. You know, we have all of these safety factors set in because you have taken that patient's ability to essentially harm you away, but you are 100% fully responsible for that patient. You know, that's why we have...
You're incurring the risk, yeah.
Correct. You're incurring that risk in making sure that you're making the best decisions for their life because it is in your hands. And I think some people take that maybe a little too lightly. In my opinion, you know, there's a reason that end tidal is set in place so that you can notice, are their respirations slowing down, and maybe you need to give that patient some ventilatory assistance. You know, we're very specific with what type of restraints we have, or if the police officer does use handcuffs, then they need to ride in the back of the ambulance with you. And, you know, you'll restrain your patient this way. And that's to essentially, out of design, to try to avoid any type of, like you said, insert your disaster here. It's
outcome,
to
right?
avoid any of that, or to avoid a bad outcome for that patient. You know, and I have a very strong opinion on that. I think the drugs are very safe. I think restraints are very safe if they're used appropriately, and the safety measures are built into the protocol for that reason.
But you just need it to go bad once, right?
Correct.
You don't want it to go bad
No,
once.
we never want it to go bad.
I had a thought when we were talking, and I should have brought this up. I had a bad experience in residency where we wanted to get locking restraints off of a patient, and nothing bad happened to the patient, but I wanted it off more quickly. And because of that, I don't know if you have one, on my ID at work, I have a key to all the locking restraints. So in case I want to put them on, take them off, adjust them, I have a key on me at all times.
Sure.
So I can go in there, unlock them, and move on with care of the patient.
I don't have that, but that's something I'm going to bring up to my leadership at the hospitals I'm at, because that's a great idea.
That's a
next
great
time they
idea.
open up the locking restraints, just ask them for a key, because there's sets of keys in all of them, and they just throw them away. Just put it on your ID. So I always have it with me.
Awesome.
That's good.
I mean,
The old skeleton key.
Pretty much. And to that point, if you're using locking or hard leather restraints during transport, know where that key is. Make sure it's easily accessible, preferably on your person, so that way if you need to get those off, you get them off.
Yeah,
The soft locking ones are easy.
soft non-lockers, and I took the different approach of non-locking hards. Right? Because I just didn't want that to be lost or forgotten about or whatever.
Hey, I need a spare.
But it's a thing out there, right? And if somebody's serious, or you have a large psychiatric population, it may be it's just the demographics of wherever you do business. Might be something to consider. It's not that expensive.
No.
And it's a one-time, it's generally a one-time. To that same point, we talked about one arm up, one down firm restraint. That's assuming the patient can physically move in that. I recall a QAing something where they were essentially forcing somebody with a bad shoulder to other decisions.
use best judgment.
Other decisions needed to be made there, and they weren't, right. It wasn't. It's like trying to push a kyphotic patient down on the backboard. No,
don't do harm.
No,
we never want to do any harm.
That wasn't the point. They had a known shoulder injury, and we're trying to manipulate that shoulder.
I guess let's not take this for granted. Why do we do one up, one down?
Can't get any real leverage.
Correct. Yeah. It's so that way we're reducing their ability to harm themselves and harm us, because we're taking away that leverage for them. And honestly, if you can't move a shoulder up, then really my biggest concern would be once someone's into 4-point restraints is their head and their torso. if they can move their head up and back and really slam it back or slam it to the side, that's the bigger concern.
Sure.
And once they have their arms under control.
Yeah.
And so, I mean, a lot of what we're doing with restraint is allowing us to assess them and minimizing their ability to do harm and maximizing their ability to ventilate. So other things we can do is sit them up if possible, if they're really sedated, decrease the risk of aspiration, increase the ability to ventilate. You already mentioned don't put them prone, but an important time to consider that is before we arrive. If they're in a struggle with law enforcement or security in some way,
good point.
they may be put prone. And what we need to do as the experts of kind of sedation and restraint is say, like, hey, we're going to sedate this person, but let's flip him over. Like, I'm worried that we may potentially harm him or kill him in this positioning, because they may not be thinking about that, and we are the ones who are thinking about it. So we need to advocate for that patient and let them know that that's what we're concerned about. And then the other thing is, what if a patient's spitting? So very frequently law enforcement will throw a sheet or a cover or gag the patient. We know that that's not ideal. And so we can kind of say, hey, let's put this non-rebreather or TB mask on the patient. If we use a non-rebreather, put oxygen so we don't suffocate this person. But we could then make sure they're oxygenating and ventilating, but also not getting saliva on us, which is no fun.
Yeah, no, those are good points. Very good points, especially in a lot of times when those patients are in the, like as you said, the Hulk mode that have probably been tasered, and to their defense, they're just trying to corral them so that we can administer a medicine so none of the law enforcement agencies, the patient, or us are harmed in that event. And yeah, it just might take that minute to say, hey, we need to reposition. This isn't okay. I know how we got here because they're throwing people off, or some of those people that are in that mode. I remember one patient specifically that was being tased, and it was just like, that ain't enough. Like, just boom, they're up again. It's just they're in that true agitated delirium, and it's like, yeah, bring it. This
Wiping the OC off.
Yeah, it's like, oh, that's not good.
So they're not going to be fun.
No.
So right now, and this is something that's coming in protocol revisions down the road. Right now, our psychiatric emergencies are really all housed under behavioral emergencies, giving you the belief in that this is strictly psychological in nature. And we understand that's kind of a limitation, and we can do better in that, and we're gonna do some tuning on that moving forward. But let's talk about these patients that are crazy for non-psychiatric reasons, right? They're hypoxic, they're encephalopathic, they're hypoglycemic, right?
Hypercarbic.
They're hypercarbic, right?
Carbon monoxide
right before they got so high that they took a nap, right? All of these cases, but we need to gain control to assess and attack the problem, right? You guys made a really good point for psychosis and using the antipsychotics like the olanzapine and the haloperidol, but do those have any place? Do those particular meds have any place in a situation like this where there's medical causation?
So when a patient is agitated and altered, you often can't figure that out. You may be like, oh, they have a history of psychosis, if you can even figure out their past medical history.
Assume you know it, yeah.
But that doesn't in itself guarantee that it's not medical. Psychiatric patients have medical problems. Medical patients that are mostly medical can have a new psychotic issue. All you know is that you have a very agitated patient in front of you, and we treat every single one of them the same, which is control the situation with a sedative and then work up anything we can possibly figure out in the field, which is why all of these people get a glucose, an EKG, and tidal, pulse ox, the works, because there's only so much we can fix in the field, and if there is a fixable thing, we need to do it because it's affecting the brain in a critical way.
I had a case like this with one of my squads. They brought him into me. Altered mental status was the thing. He's a paraplegic or quadriplegic trait. They failed to put end-tidal on them because if it's a trach, you just put on the same thing you would for your ET tube to check.
No, it's a standard airway adapter size,
So came in, I assessed him, part of my workup, I got a venous blood gas. Oh, lo and behold, his CO2.
Triple digits.
Yep.
Yeah, for sure.
I'm like, you know what? Just for a learning opportunity, we're going to stick a...
Go get your machine, yeah.
And it was in the 80s, right? Yeah. End-tidal CO2 was 80. I'm like... We don't know what's going on.
It's at least for that, right?
He's got a trach, probably has some breathing issues, might be reasonable to, do all your things, but also include end tidal onto that. And that's why I bring up because of that specific case.
Hypercarbia, yeah. I haven't had that patient that was combative that was hypercarbic. I've had him certainly obtunded because of hypercarbia.
He just hit that sweet spot where
He
he
hit
was
that
hypercarbic enough to be
There is
awake.
that, right, yeah, there's that middle ground. Certainly combative hypoxemia, you know, I've seen a bunch historically, but...
and probably the most common one we see would be like a diabetic.
Yeah, it's
I would say
hypoglycemia.
hypoglycemia is probably the most common one that we see where, you know, most of the time we know they're a diabetic and we're just trying to make sure they don't injure themselves. They don't obviously hurt us, but we can just simply give them some, you know, D10 to try to correct their sugar problem, and then that goes away.
Yeah.
But sometimes a patient who's hypoglycemic can become profoundly agitated and may even be so agitated that they need to be ketamined in order to actually administer D10 or something.
To determine that you even need to.
Or
Yeah.
administer. And that's okay. It's not that we inappropriately gave ketamine. They needed to be sedated so that we can figure out and fix the underlying issue.
But that's why we follow every single administration with pulse ox, capnography, glucose, as a EKG, as a
full broad assessment to make sure we're trying to figure out what's going on with them.
Is are there treatable causes, right? Because obviously it'd be a shame to take control of the situation and have the patient subsequently die from hypoxia, hypoglycemia.
Something that we can actually fix in the field, because it may not. They may be dying of something we can't fix, but that's why we controlled the situation and brought them to the hospital. But if we can fix it, we got to fix it.
We have to fix
for sure.
it, absolutely. As far as documentation of these cases, we've baked in the RAS score into these behavioral emergencies and for these combative patients. When do you all expect us to do the RAS score and have it documented?
So from my perspective, it's not mandatory, but it's better documentation to do it. It's not mandated by this state, but some of our neighbors, it is built into their protocols, and it is mandated that if they give ketamine, they have to give a pre-ketamine RAS, post-ketamine RAS. So it's just a kind of objective way of measuring agitation. But if you document well that the patient had X kind of serious agitation, this is how agitated they were, in order for me to adequately treat them and protect both the patient and myself, I gave ketamine and then did all the right stuff afterwards, then I'd applaud that and say that's perfect, and you didn't even need to use a RAS. But if you just wanted to augment it a little bit more and say RAS was +4 and then RAS went down to -4 or -5 after ketamine, I'd be like, sure, I know objectively where they were and now where they're
and
after.
Where they're at, And we were kind of talking offline is, yes, you need that pre and post to quantify that, but the expectation, at least as you know, from anybody I've interfaced with in our team, is you're not stopping what you're doing to do the numbers and then be like, okay, this is my trigger point. I mean, you intuitively know if somebody's trying to kill you, your partner, or themselves, right? You can come back after the fact and be like, here's where they were, right? I know I've got some pushback, and hence the reason for the question, right? It's like, you expect us to do this when we're fighting? Come on, man. No, of course not.
No, but you're going to document they're combative, right?
Yep.
I'll be honest, I'd look it up. +4, nailed it. Then you've got very agitated, +3, +2 is agitated, 1 is restless, and 0 is alert and calm, right? So 0 is your baseline. And then we're really kind of shooting for like that drowsy. If we gave them ketamine, we're going to expect them to be a little more than drowsy, which is going to be -2 to like light sedation, which is the ideal place to be. If you're further on down that to moderate sedation, deep sedation, or unarousable, ketamine sedation you might get to unarousable.
Right,
sure.
We know that that's going to happen, but that is because we're going from one side of the RAS scale
to the other. Right.
Yep. And it's okay. And I have freaked out some police officers after I've given some ketamine. Like, they're not doing anything. I'm like, perfect. Nailed it.
Right.
But that's all the RAS scale is. It's very easy. It's combative to unresponsive, and the middle is alert and calm.
There's a subplot to that. More often than not, you give them the ketamine dose and they go from one end to the other, right? They go to unarousable. But when you give them if you have the case where you give them and they don't go to completely unarousable, they just go to sleepy, right? you haven't failed, right? You still have taken control.
That's okay.
And that's okay. And your job is not to make them unarousable, right? And I know our colleague.
Well, ideally, we want to get everyone to calm,
yeah.
right?
Mm-hmm. Yep.
That's where we
Right.
want them at. We want you at calm.
But there's this misconception that the expectation is out, and that's not necessarily the goal. We often get there, right?
With
a
sedation,
single
yes,
dose.
but let's look at Narcan for opioid overdoses, right? The goal of the Narcan is to get them to breathing on their own, not awake and vomiting.
Right.
Or even just awake. The goal is ventilating normally, not awake.
Yep.
If they wake up, great, but we don't want to throw them into withdrawal.
Yeah. And
Yeah, or wake up violent too.
Right.
Yeah.
correct. Yeah. Yeah. The point is with whether it's the Narcan or if you hit the
Yep.
if you hit the minimum middle ground, which is I've made this scene safe, right? Whether
Yeah.
it's from a breathing perspective or whether it's from a combative, you're where you need to be. You don't have to go to the extreme. And like I said, like I started to say, one of our colleagues had a situation where the patient was awake, but still talking to the patient, to the crew after, still yelling at the crew, but not assaulting the crew anymore. So they gave him more ketamine to put them completely out. And that's the point that I wanted to stress there is
Now you're just making more work for yourself, and you're putting the patient in increased danger. because of what
unnecessary
you're doing.
risk. Yeah. Whereas if they had moved them from violent to agitated, if they wanted to then give them a little extra benzo or something like that, probably wouldn't have been frowned upon. But that was just kind of a misinterpretation of expectations is kind of what I wanted to make sure we were.
Well, and
out
oftentimes if
there.
you get them from combative to, yelling at you, but you can have a conversation with them and you can walk away and have them calm down.
Let them calm down,
They might
yeah.
slip down to where you want them at. They might go into the sleepiness phase.
Over
Yeah.
time.
Yeah, the best sedative is your voice. I mean, if you're able to sedate someone with your voice, that is perfect. Doesn't always work, which is why we have chemicals. But obviously, de-escalation techniques are the best if we can get away with it.
If they're going to accept your de-escalation.
they may not.
They may not, right? Yeah.